Hello everyone, welcome to Pediatric Nursing 2. I'm Ms. Keenan, and today we are going to learn about hematology system disorders and nursing care for children with anemia, thalassemia congenital, idiopathic thrombocytopenic purpura, and leukemia. So the objectives are to learn about these diseases, anemia, thalassemia, idiopathic thrombocytopenic purpura, and leukemia, and how to administer the deferral therapy. So remember in Pediatric Nursing 1, we have learned about hematological assessment on children, and we have learned that the blood was made in the liver, and we have the stem cells, and we have three types of blood: red blood cell, white blood cells, and thrombocytes or platelets. And we learned in pediatric ones about those normal functions, and today we are going to learn about the diseases that related to each of the blood cells. And the first disease is anemia. So as you can see here on the picture, you can see that this is the normal blood cell. You have your red blood cell, you have your white blood cell, you have the platelets. And in anemia, what happened is that the number of the red blood cells, the one that transporting oxygens, are actually not much. So we have a reduction or decreased number of red blood cells. So we have less ability for the blood to transporting oxygens through the body. So this is what happened. And anemia, as I mentioned before, is when the number of red blood cells or RBC or the hemoglobin or HGB or HB is low or below normal values. And it means that the capacity for the blood to carry oxygen is reduced. And the classification for anemia can be divided into two according to etiology or physiology, which is manifested in the erythrocyte or the depletions of hemoglobins, and the morphologies, which includes the size, shape, and color changes of the red blood cells itself. So these are types of anemia. We have iron deficiency anemia because of lack of iron. We have folic acid deficiency because lack of folic acid and grainy leafy vegetables. We have pernicious anemia because we have a lack of vitamin B12. And we also have the anemia that is lead poisoning. So it is a toxic effect from leads that affect the bone marrow, erythroid cells, nervous system, and kidney, and this interferes with the productions of hemoglobins or the biosynthesis of heme. And we also have aplastic anemia, so when the bone marrow fails to produce the blood cells, so we have what we call bone marrow aplasia and pancytopenia, so the number of the blood cell is really decreased. We also have what we call hemoglobinopathies, so the size or the form of the red blood cell has a problem. So we have sickle cell anemia, where the hemoglobin is in abnormal form like a half moon or a sickle cell. And we have also thalassemia, which is a genetic disorder actually in the reductions of the production of normal hemoglobin. So instead of making a productions of a normal round hemoglobin, the form of the thalassemia red blood cell is different. So sign and symptom of anemia is sometimes asymptomatic because the body will just adjust to the conditions, but we need to run a blood test to see how's the hemoglobin and hematocrit levels, so we can then judge whether it's lower than the normal or not. But then the initial signs of anemia sometimes become cyanotic, fatigue, shortness of breath, headache, difficulty concentrating, dizziness, and even pale skin. In moderate to severe anemia children, they will have an overt signs and symptoms such as they will be irritable, they'll be fatigue, delayed motor development, tachycardia, shortness of breath, as well as decreased activity level, pale skin, listlessness, and also we can hear systolically heart murmur because the heart is lacking of blood and it's trying to maintain the needs of the body, so we can hear the murmur. And we can also have hepatomegaly, and sometimes which can lead to congestive heart failure. So the diagnosis of anemia will be made through a history and physical examinations, as well as the complete blood count and reticulocyte count. So here what we're counting is the hemoglobin itself, the iron containing pigment of red blood cells that carries oxygen from the lungs to the tissues, and also the hematocrit. So how many of red blood cells composed in the whole blood? How many percent? Well, normally, the number of hematocrit will be 3 times the value of hemoglobin, so that's the normal. If it's less than that, it means we have anemia. Now, I put here a box that is very useful for us to understand if you're doing a CBC, how to read them. So we have three blood elements, right? The red blood cell, white blood cells, and the platelets or the thrombocytes. So when increase happen in the red blood cells, we call it polycythemia. When the white blood cell is increased, we call it leukocytosis. When the thrombocytes is increases, we call it thrombocytosis. And when the things are decreasing, so if red blood cell is decreasing, we call it anemia. If white blood cells is decreasing, we call it leukopenia. And then when the platelets is decreasing, we call it thrombocytopenia. So that's how you remember each term of medical term that is very useful for you to know, oh, there is something wrong with the blood elements when you are evaluating the complete blood count. Now, how to care for patients with anemia? Of course, we need to identify first the cause of anemia. What's the cause? Is that iron? Is that poisoning? Or is that B12 the problem? Or is it just because the body is not making it? So once we know the etiology, we can then plan what we can do. For example, if it's mild anemia, we can also work it out through diet or even just vitamin supplements, taking more iron, taking more vitamin B12, or even eating greeny leaf vegetables. And in a severe and moderate and severe conditions, obviously we will need the RBC transfusion. And anemia actually because of the decreased productions of red blood cells. So when we administer the hematopoietic growth factor, we hope that the productions of the red blood cells will be higher. So then we can have more blood cells to then care for the anemia. For educations to the patients, we can educate the patient and the family about the activity that the children can take. There will be the signs and symptoms that we need to be aware of for our children if they have anemia. And we can also alter the diet so that the children will have a high iron diet, as well as when needed, we can collaborate to get iron oral supplement for the children. Next problem is still by the red blood cell, but this is what we call thalassemia. So it's a congenital problem where I mentioned before, like the normal red blood cell will then have a malform of red blood cells. So instead of the rounded one, it will be like a square one, and this is when thalassemia happens. So yes, it still can transport oxygen, but not as efficient as a normal red blood cell. So still there will be a sign of decreased oxygen supply, hypoxia in the body of the patient. So, as I mentioned, it's a genetic disorder. It's the reduced productions of the normal hemoglobin. So it's the not normal, abnormal hemoglobin that is presented. And why? Because there are two types of thalassemia. The first one is alpha thalassemia, where the chains of alpha inside the hemoglobin is being affected. And the next one is the beta thalassemia, where the beta chain of that red blood cell is being affected. And for the beta thalassemia, we have three subcategories. The first one is thalassemia minor or B thalassemia trait, and this is like mild microcytic anemia, so we don't need any treatment for this condition. And we have thalassemia intermedia, where the child requires blood transfusion to maintain the adequate quality of life. And then the third one, the major one and the common happen, is the beta thalassemia major, or we call it coolie anemia. So here the child requires ongoing medical attentions and even blood transfusions, and also iron remover, or what we call chelation therapy, using medicine that we call Tasfro. So let's talk about the alpha thalassemia. So in alpha thalassemia, as I mentioned before, the alpha chain is the one that is affected. So instead of um, having a normal one of a red blood cell, it's making a mistake, and then sometimes it can be mistakenly diagnosed also as iron deficiency anemia. When one or two chains of the alpha genes missing, sometimes we cannot really see the sign and symptoms, so it will be asymptomatic, or sometimes it could also lead to mild anemia. When three of the alpha chains missing, what happens is that the person, the baby, will have hemoglobin H disease. What is this? This is excess beta chain, and it's the minimal productions of the alpha chains in the bone marrow, and then we will develop what we call hemoglobin H. So what is hemoglobin H? Hemoglobin H is actually the red blood cell that has the oxygen carrying capacity but with decreased effectiveness. So the patient will then present anemia and splenomegaly. So this is the not functioning very well red blood cell. Next, we have the type of beta thalassemia major or coolie anemia. So in here, we have the beta globulin chain in hemoglobin synthesis that is reduced or entirely absent. So what happened that when the chains is not present or is there but it's not stable, the RBC that is produced become rigid and easily hemolyzed. So what happened, the patients come with a severe hemolytic anemia and chronic hypoxia, of course, because the body cannot have the ability to gain the oxygens to every cells, because the red blood cells are not there, it's hemolyzed. So what happened is the body also tried to make up that by increasing the erythroid activity. So what happened is massive bone marrow expansion and thinning of the bony cortex. So every single bone is being asked to contribute more to make red blood cells. What happened? As a long term, there will be growth retardations and pathologic fractures and even skeletal deformities. So what we can see in patients with beta thalassemia major or coolie anemia, that the frontal bone and the maxillary bone will be projected out or bossing. So that's because the body is trying to make more red blood cells by having expansions to each bone that they can use, the body can use to make red blood cells. So what happened in beta thalassemia? Another conditions that might happen, because we know beta thalassemia can need to rely on blood transfusions all the time, what we call hemosiderosis. Hemosiderosis is the conditions where we have a lot of supply of iron because we just need to make a lot of red blood cells as a complication. So this is because the body having a very rapid hemolysis of red blood cells and decrease the hemoglobin's production, but then the body still have increased conditions of response to take more dietary iron. So for there, we will have the condition hemosiderosis. And when we have excess iron in our body, what will happen is that we have a bronze pigmentations of the skin, we have changes in our bones, we will have altered organ functions, especially for the cardiac system, splenomegaly, endocrine abnormalities, osteoporosis, because the bone just gone. We use the bone marrow, liver and gallbladder disease, and also sometimes like ulcers. With the symptoms and signs of beta thalassemia, sometimes it's symptomatic what we can see is there is liver enlarged, spleen enlargement. We can also sometimes see mild jaundice because not so many red blood cells going on. We can have growth retardation. We can even have moderate to severe anemia because there's not so many red blood cells. And then obviously the hemoglobin will decrease. When we do a CBC, complete blood count, we will see a very low number of hemoglobin, and we can have the severe anemia where we can have also the bony deformities because bone marrow just try to make up the missing. And then the body will of course become susceptibility to infection, so it increases the possibility to get infected because the spleen is just working too hard to do the other thing. Meanwhile, it cannot give so much protections toward infection. So how to diagnose? Of course, through history and physical examinations to the patients, as well as laboratory tests with CBC, complete blood count for the red cell indices. And we will see that there will be decrease in the hemoglobin and hematocrit, hypochromia, microcytosis, low mean corpuscular volume, and also increase in reticulocyte count. What we can do as nurses to do nursing care, we can prevent hypoxia by providing blood transfusion therapy, usually every 3 to 4 weeks for the child's lifetime. And the child will also be dependent on transfusion therapy to maintain their hemoglobin and to improve their quality of life and to prevent extramedullary hematopoiesis, to promote growth and development, and to reduce infection. So we just need to give the therapy of transfusion because we know that they cannot function without the red blood cells. It's just like a car without the fuel. So you just have to give the transfusions for the children. And there will be numerous complications. For example, high risk for developing hemosiderosis, the accumulations of iron. What we can do also, if we want to cure these conditions of beta thalassemia, is to do a bone marrow transplant. So we find a donor, and if it matched, then we do the bone marrow transplantations. But the nurse needs to address the importance of blood transfusion therapy and also the chelation therapy for compliance. So both of them, they have to go together, the blood transfusion and chelation therapy, because too much iron cannot be extracted manually by the body, so we do need help with the chelation agent. And we also need to teach how to do the chelation therapy at home because it took a long time. And we also need to do a teaching for a good hand washing because the patient will be prone to infection and we don't want to cause any other problem. So we can also teach the patients, if you have fever, probably you can take antibiotics as a prophylaxis before the infections happen. And we also have to educate the parents that maybe if they're planning to have another child, the child may inherit the same disorder, so they have to think through it. Well, we talk about hemosiderosis now. So it's the accumulations of iron. So because of the lot of blood transfusions, the chronic conditions of every single week, you get blood transfusions. In 1 unit of blood, there might be 200 milligrams of iron, and it's accumulated in the body. And body just doesn't have the mechanism to remove the iron. So the iron will be stored inside tissue and organs, and the hemosiderosis conditions will be happening. And what we do is we need help. So we need to treat this so that we prevent the toxic levels of iron inside the body, and even we prevent death because of the poisoning of iron. So what we do is we remove the iron by using the chelating agents that binds with the iron and allow the secretions of iron through the urine and stool. And the main chelating agents that we know is the deferoxamine B, or what we call desferol. And how to administer? So this is desferol therapy. It's an IV, it's an intravenous for injection, and subcutaneous or intramuscular. So it's like 500 milligrams per vial. So the doctor will prescribe, and we have to teach the patients how to administer them. So what we do, with this medicine, all the iron will be rapidly excreted in urine and also in some stool. And we administer this intravenously or subcutaneously over 8 to 10 hours. So usually this will be at that time at least 5 days a week. And then we can, the patients with thalassemia, sometimes because they undergo transfusion a lot and we just don't want them to have poking every single time, so we installed like a port, either in the tummy or in the big vein in their body, like a portal where we can just insert the butterfly catheter and administer the drug via infusion pumps at home without any difficulties. And I know that this treatment will be very burdensome for the parents. It also be expensive, and sometimes the issues of adherence, that you have to do it all the time, make it terrible. But then we have no other choice. When we need the blood transfusion, we just need to do the chelating treatment for our kids. And what we do to check if the iron level is okay is to do a routine check for the iron level. And in the long-term complications, if we are not checking the iron levels, we might have what we call hearing loss, diabetes, and organ failure, and even death. So actually, they have found that the oral version of the Desferal, what we call the Furasyrox or Exjade, and this can be prescribed orally, and it's well tolerated and with minimal gastrointestinal effects on our patients. But then it can only be consumed at least the patient is 10 years old. So it comes with different dosage. So we have 125, 250, and 500. So according to the dosage needed by our patients. And you can watch one of the video about the patients who is undergoing Desferal therapy every night in Learn, and then just make a summary about what you learned from that video. And now we move to another type of blood cells, which is the thrombocytes, with the disease of idiopathic thrombocytopenic purpura. So what happened here is the body produces antibodies, and the antibodies then attack the thrombocytes. When there's infections, the antibodies that was built because the infections not only attack the viral but also attack the thrombocytes. So what comes out is the purpura under your skin. So we can call it idiopathic. We can call also immune. So it's like autoimmune thrombocytopenic purpura. What happened? It happens to kids 2 to 10 years old, mostly thrombocytopenia in the childhood. So the level of the thrombocytes is lowering, and then the cause is unknown, but it's related to autoimmune response for the disease, related to the antigen. And then what happened is that once the viral infections happen, body produce antibodies but also produce antiplatelets antibodies, and these antibodies destroy the platelets. So what happened? We develop fatigue, we have purpura, and we have excessive bruising in the body. So that characteristic, we have thrombocytopenia, number of destructions, excessive destructions of platelets. We have purpura, those discolorations because of tachy under the skin, and they colored pink. The color is pink, so we call it purpura. And the tachy is like pinpoint hemorrhage that occur anywhere in the body and do not blanch when you pressure it. So ITP can happen for 1 to 4 weeks after viral infections and in young children, and it just recovers spontaneously. So the complication might be severe hemorrhage and bleeding into the vital organs, and sometimes intracranial hemorrhage, but it happens rarely. So there are two types of ITP, acute ITP and also chronic ITP. So the acute ITP is often a benign one, and it's self-limiting and often occurs in children younger than 13 years old after infections such as upper respiratory infections, measles, rubella, mumps, chickenpox, and sometimes also parvovirus B19. So what happened is that the normal platelets will come within 6 months without relapse. So it will be normal within 6 months. And 90% complete remissions without relapsing, and 10 to 20% of the patients will then develop to chronic ITP. So the chronic ITP often happens in adult with the persistence of thrombocytopenia, where the thrombocytes level is less than 150,000, and it lasts longer than 6 months and related to a systemic problem or SLE, systemic SLE, a lupus disease. And what is the sign and symptoms of ITP when we see our patients? So healthy children, actually they have nothing, but they have viral infections, recent viral infections, and they suddenly presented with pecky, bruising, mucus, bleeding, and epistaxis. And sometimes, rarely also happening the internal bleeding, such as intracranial hemorrhage. And some of the female adolescents may also complain of menorrhagia, so just excessive bleeding from their period. And how to diagnose? Actually, through history and physical examinations, and we need to see the history of bleeding, history of bruising. We do the CBC again, for sure, and we do also peripheral smear examination, coagulation analysis, and possible bone marrow aspirate. So we do the PT, prothrombin time and thrombin time study in this case to see how long is the bleeding factors. And sometimes we can just isolate that it's ITP when we see the severe thrombocytopenia, where the thrombocyte is just less than 20,000, where the normal platelet counts will be 150 to 400,000. So in the acute ITP, it's a spontaneous resolution without no treatment. So the children, when they came into the hospital with less than 20,000 platelets and asymptomatic, the doctor will just say they don't need treatment, but just monitor the number of their platelets. And when the small children or another active children come with bruises, pecky, and platelets still lower than 20,000, so you just need to do aggressive treatment to just avoid the intracranial bleeding. But then when the patients come with severe bleeding like epistaxis, you just have to make sure that you help for transfusions of platelets. But again, transfusions of platelets needs to be considered, because once we put platelets, the body will then make another antibody that will also destroy the patient's own platelets. So that's what we need to be aware of. So as a nurse, what we can do, the nurse need to know that the first line of treatment when we have ITP patients is including steroid administration. So steroid here be used to compress the inflammation reactions of the disease. So we can also give intravenous gamma globulin or IVIG administration, and we can also put anti-D antibody administration or Winrow. And the children with extremely low platelets and acute bleeding needs to be hospitalized, because we need to do close observations on the bleeding. And during the hospitalization, we can also provide IVIG intravenously 2 to 3 days course. This actually, we need to prevent the antibody to attach to the platelets, and we don't want they to destruct the spleen, and we want that the platelets will will rise within 48 hours during the hospitalizations. So remember that the intravenous gamma globulin, the IVIG, is actually a blood product, so you just need to go through the consent with the patient and how they are dealing with blood product transfusion. Next one is to teach the family the importance of safety. We don't want the patient to have a contact risk sport, high risk activity, bike riding, roller skating, riding with motorcycle, no. And teach how to manage bleeding at home. If they have a minor cut, scrapes, or nosebleeds, what to do. We need to lean forward, pinch the nose, breathe, and apply ice in the back of the head. And avoid of using acetyl salicylic acid. So this is like the children's aspirin, because this help to make more bleeding to the patients. And we also ask them to not do any injection, straight and razor, use the tampons, and even inserting the thermometer to measure temperature from the rectum, because it might cause another bleeding to the patient. The nurse also must report the signs of bleeding immediately and try to provide a safe environment to prevent trauma. So we use padding in the crib, use nail file instead of nail clipper. And when this is a patient with chronic ITP, we ask the patient to wear a medical alert bracelet, so people will understand that you are fragile in bleeding. So people will then raise their alertness and awareness to take care. So, talking about hematologic disorder, what are the nursing diagnoses that we can bring in? The first one is pain. Remember that pain is really essential here, because, as we mentioned, every single thing needs to be due by the complete blood count, where you poke the patient, poke the patient, poke the patient, do venipuncture, venipuncture, and venipuncture every single time. So we need to make it automatic here. How? By educating about the EMLA, or topical analgesics, that will be useful, very useful, to reducing the pain before the venipuncture. So what we need to do, we collaborate with the parents 1 to 2 hours, 1 to 2 hours before coming to the hospital, apply a lot of the EMLA, and then coming to the hospital for a poke. And sometimes we can also give support by, when they're being brave and doing it nice, we can just give stickers for the patients. And another nursing diagnosis is fatigue, impaired physical mobility, of course, ineffective health management, anxiety, because sometimes they are just anxious to get the poking. And what's the result after the poking? So we just help the patients to find their favorite activity in their stressful situations, as well as help the family with the ineffective coping. We teach us how kids relieve their stress by singing, by dancing, reading, even sleeping. Remember that the child is also in risk for injury and also in risk for infection. So we just make sure that we do intervention related to this condition. The last condition is what we call leukemia. So it's different from the other conditions that we've mentioned before. So in leukemia, what happened is that this is normal blood cells. We have the red blood cell, we have neutrophils, we have monocytes, we have platelets. This is normal blood cells. And in the leukemia, what happened? Instead of having the normal cells formed inside the body, we have, or we built somehow, the leukemic cell. So the leukemic cells will then dominate. So then there will be a problem through the to the red blood cell, white blood cells, and the thrombocytes. So leukemic cells is present. So as I mentioned before, this is a type of cancer, and 1/3 of the childhood cancer is actually leukemia. And the primary disorder started in the bone marrow, where actually the normal elements are being replaced by abnormal white blood cells. So this is a normal one. So we have the bone marrow, there is the stem cell inside. The stem cell then will be the myeloid and the lymphoid. So lymphoid will then become lymphoid blasts and then build the white blood cells. And then the myeloid can build the myeloid blasts, and there will be red blood cells for sure. And we have platelets, and we also have white blood cells. Then what happened during the normal, configuration? Suddenly the leukemia cells develop at any time, and then, well, ta-da, we have leukemic. So that's the abnormal condition. So the types of leukemia is divided into two: acute leukemia and chronic leukemia, and lymphocytic leukemia and myelogenous leukemia. So this is like what type of the blood cells blast that is being affected. So with acute leukemia, it's a rapid progressive disease affected the undifferentiated or immature cells, where the cells without the normal functions. So acute lymphoblastic leukemia and also acute myelogenous leukemia. And in chronic leukemia, this is a very slow progress of the disease where we have the maturations and the differentiations of the cells, but the cells do have some normal functions, although it's not like, not the right. And how to see the complications? So leukemia is complicated because it can be metastatic to another organ system like the blood, the bone, the CNS, the spleen, the liver, and other organ, and also it will have the alterations in growth and development to the children. The late effects will have neurocognitive functions and ocular, cardiovascular, and thyroid dysfunction. But as you know, behold, this type of cancer, leukemia, is actually curable. Well, it will be relapse in some cases, but with poorer prognosis, but you can still cure leukemia. How to cure? With also bone marrow transplant. So the types of leukemia, we have ALL, or what we call acute lymphocytic leukemia. So this is how it looks like under the microscope. It's a most type of cancer, peak incidence 2 to 5 years old, more to boys. The sign and symptoms, of course, is leukemic cells to the bone marrow and other organs. Patients will come with fevers, fatigue, lethargy, anemia, and pain, anorexia, bone joint pain, limp, or just refusing to walk because it's painful, headache, vomiting, difficulty of breathing, low urine output, bleeding, tachy, abdominal distensions, enlarged spleen, and even enlarged lymph nodes and hepatomegaly. So these are the signs and symptoms for ALL. And how to diagnose? Of course, again, poking the bone marrow aspiration. So doing the lumbar puncture to take the bone marrow to see what is there, doing the CBC to see how much or how many the white blood cells that we have, and checking the chromosomal abnormality to the bone marrow, through the bone marrow, to evaluate what is going on with the central nervous system. Sometimes you can also do the chest radiography to just make sure whether the mediastinal have a mass and whether the liver and the kidney also got a problem because of this messy blood consistency of the leukemic cell. So what can we do as a nurse? We help with the chemotherapy because this is cancer. So we do chemotherapy. There are 3 phases. The first one is remission induction. So we just cut every single thing. Tumor is reduced until we cannot detect the level of the cells. And remissions like complete heal in 4 weeks. What can we use is chemotherapy agents such as vincristine, L-asparaginase, prednisone, or dexamethasones. And some children with a poorer prognosis can also receive another type of drugs like anthracycline, so that this will clean every single thing. Actually, this is affecting the heart, but that's okay because it can help the leukemic cancer cell to be gone. We can also do a CNS prophylaxis chemotherapy by injecting the chemotherapy agents intrathecally in the spinal canal to the CFS during the lumbar puncture. So we just want to make sure that there's no leukemic cells inside the bone, the spinal side. What else is the phase 2? So we do consolidations. After phase 1, the induction remission kill everything. We then continue to destroy all the residual leukemic cells. We start immediately after the remissions and last about 6 months. So here we are doing the chemotherapy in high dosage. So we want all the cells to be gone, like healthy, and sometimes if needed we also may require radiations. In the phase 3 we will have what we call maintenance. So this is the controls of the leukemia. This can last 2 to 3 years after diagnosis. Well, remissions 95% in cases, so there is no relapses, but 15 to 20 there are still relapses and continue to build the chronic conditions of leukemia. Now, you want to cure it, you do the bone marrow transplant. So bone marrow transplants can be done after 2 remissions. So healthy, but then sick again. And then you give a high dose of chemotherapy and radiations to like really wipe out all the cancer cell. And then you rescuing the new stem cell to the bone marrow for recovery. There are 2 types of bone marrow transplants. Autologous transplant, so the patients already know that will develop leukemic, then they already have their own blood bone marrow, and then before they're sick, and then when they're sick they just injected it back. So that's called autologous. But then they also have what we call allogenic transplant. So allogenic is like the transplant of bone marrow from the matched sibling, relatives, or even just donors that we match, and we see that, oh, it's a matched bone marrow, so yeah, we can do the bone marrow transplant. So during the bone marrow transplant, we also will see what will happen to the body, because sometimes it's successful transplantation without the rejection from the body cells, but sometimes there are also rejections from the body cells. And next is the type of acute myelocytic leukemia. So the myelocytic cells is having problem here. It's the second most common leukemia in children, happen from birth to 10 years old, happen equally in the boys and girls, and it affects the differentiation pathway of the myeloid progenitors or precursors rather than abnormal growth kinetics. So because of it happening in the myelolytic cells, so the 3 type of blood cells can be affected by this condition. And the symptoms are fake. Sometimes it's just like flu with abnormal blood count, but then you definitely have decreased number of RBC, decreased number of platelets, decreased number of WBC or white blood cells. Patients will have bone pain and arthralgias, and sometimes also blueberry muffins or lesions or sarcomas because of the condition. So what we do to know there's the decreased number of this and that, again, is a CBC, complete blood count. So that's very important in our patients. And we can also do diagnosis through the bone marrow analysis. So in the bone marrow analysis, we do the biopsy to just make sure that whether the cells is malignancy or benign, to make sure how is the prognosis of this disease. What nursing care we can do is we do the induction treatment. It's like chemotherapy again, but induction treatment only, not with the phases. And we do a combinations induction therapy with citrabine and daunorubicin, and sometimes we can also use cytarabine and also anthracycline to just combine everything, and also use etoposide and thioguanine to just make sure that which one is really work very well to the patients. Sometimes we can also give anthracycline as an induction regimen for the children, or we can use daunorubicin and idarubicin as well for the treatment. Like all this medicine is for chemotherapy to just make sure that all the cancer cells are gone from the patient. Next, if the patient's remission, healthy, get healed, that's good. But if the patient's relapse, then we can have the chronic myelogenous leukemia. So the hematopoietic tissues account for these conditions in childhood leukemia, where we have what we call Philadelphia chromosomes. So these Philadelphia chromosomes is the one that causing the chronic myelogenous leukemia. And sometimes this disease also associated with the exposures of ionizing radiations, but not every children have that. It's just happened that you have the Philadelphia chromosomes. So the signs and symptoms are non-specific, but patients presented with fever, fatigue, weight loss, and anorexia. And we have the initial chronic phase, where we have the chronic the malignant clone, the cancerous alterations of the blood cells, and we have the elevated leukocyte count with increased numbers of immature granulocytes, and the CBC also revealed mild anemia and thrombocytosis, like the increased number of platelets. And actually here, the spleen will be enlarged, and patients will come with complaints of pain in the left upper quadrant of the abdomen. So we have to make sure to assess the children if they have pain on the upper quadrant of their abdomen. And this chronic phase actually happened 3 to 4 years after the crisis, the blast crisis phase we call. And at this point, the blood count will rise dramatically and cannot be controlled with the drugs. And how to diagnose? We of course see that there are increased numbers of myeloid cells from the blood, from the bone marrow, again, bone marrow, and from the peripheral blood smear. So we see that there's not normal findings in the blood smear. And cytogenic studies also will help us to figure out whether the Philadelphia chromosomes is actually inside the blood of the patients. As nurse, what we can do to help the patients with chronic myelogenous leukemia, we treat the signs and symptoms. So if we can control, we can use the hydroxyurea to help, and this will help the patients to have the leukocyte number gradually return to normal. We can also do interferon A therapy, and then this is the remissions is 70% of the patients get healed. By that, there will be also cytogenic remissions in 20% patients. We can also do combination therapy, just like the other conditions with the combinations of the chemotherapies. And also we do bone marrow transplant, allogenic bone marrow transplant or stem cell transplantations from siblings or basically from the donor. So when talking about neoplastic disorder, what are the nursing diagnoses that we can have? We can have risks for infection. We can have, because in leukemia, the children, they're going through chemotherapy, so obviously they don't have their defense, platelets gone, everything's gone, no protections from themselves, they tend to have infections. And patients obviously being poked for lumbar puncture, being poked for CBC, pain. So we need to just normalize the use of EMLA everywhere in our patients with hematologic disorder. And they will have impaired oral mucous membrane, nauseatic, imbalanced nutrition, they just don't want to eat, constipation, diarrhea, risk for skin integrity, activity intolerance, disturbed body image because they lost all the hair, and sometimes also risk for situational low self-esteem and also compromised family coping and anticipatory grieving. So these are the nursing diagnoses that we can use to take care of our patient. So notice that at the website, the Learn, I've put a lot of videos that we can watch and also the medical leaflet, medicine leaflet. So I want you to read and watch them and write for me 9 sentences related to each video. Well, happy studying! These are the list of references that I use.